खिड़की बंद करो।
We are live.
Hello. Good evening, everyone. We welcome you to the 38th episode of the AIOS ARC teaching program, a PG teaching program with a difference where we explore theories and themes which are not readily available in textbooks. The Journal Club series is also a part of this PG teaching program. And today we have two articles from the subspecialty of cornea, which shall be presented by our very, very enthusiastic presenters and then discussed by the mentors and discussants. I thank all the presenters, the mentors, and the discussants for their presence here this evening. I also thank all the audience who has logged in. Before we start, I would request the audience to make it as interactive as possible. You can post your questions in the chat box, and we'll be taking them up as and when they come at the end of the article presentation. We have a stellar panel of discussants with us today, this evening. I welcome them. We have Dr. Vardhaman Kankaria, who's the director of the Asian Eye Hospital at Pune. We have Professor Rohit Shetty, chairman of the Narayan Nethralaya in Bangalore. And we have Dr. Srinivas K. Rao, the director of the Darshan Eye Care and Surgical Center, Chennai. Thank you all so much for being here this evening. I'm sure your comments are really going to add to this CME. Our mentors this evening are Professor Chintan Malhotra, who is from PGI Chandigarh, from the Cornea Lens and Refractive Services at the Advanced Eye Care Postgraduate Institute of Medical Education and Research, Chandigarh. And we also have Dr. Rama Rajagopal, who's the Director of Cornea, Eye Bank and Refractive Surgery at Shankar Nethralaya, Chennai. Thank you so much for being here and welcome to this journal club. Our presenters this evening are Dr. Aarti Rajkumar, who's a junior resident at Shankar Nethralaya, Chennai, and Dr. Lekha Chandel from PGI Chandigarh. So we're looking forward to the journal articles that you're going to be presenting. Our first presenter is Dr. Aarti Rajkumar from Shankar Nethralaya, Chennai, and she'll be presenting her journal article on the comparison of long-term visual and refractive results of transepithelial and mechanical photorefractive keratectomy. So I welcome you, Dr. Aarti, and over to you for your first journal article.
Thank you. Thank you so much, ma'am. I'll just share my screen. Okay. Okay, is it visible?
Yes, it's visible.
Okay. So coming to the topic for the journal club today, it's the comparison of long-term visual and refractive results of transepithelial and mechanical photorefractive keratectomy. It will be presented by me, and my mentor is Dr. Rama Rajgopal, ma'am. These are the headings under which the article is going to be discussed. Coming to the okay, so the MARI index is an index that gives us a way to critique a study. M stands for methods, then there is assignment, assessment, results, interpretation, and extrapolation. We'll come back to this towards the end of our presentation. Coming to the introduction, photorefractive keratectomy has been used as an effective and safe refractive surgical technique for many years. With the advent of LASIK, the use of PRK has been reduced. However, it still remains a good treatment option for patients with thin corneas, basal membrane alterations, and to correct any residual refractive error post LASIK surgery. In transepithelial photorefractive keratectomy, an excimer laser is used for the epithelium removal, whereas in mechanical photorefractive keratectomy, a blunt spatula is used. Higher order aberrations that are seen after excimer laser surgeries do pose a problem for the patients. And the epithelial removal technique that least affects the higher order aberrations is still under debate. Coming to the aim of this study, it is to present and compare 2-year results of mechanical photorefractive keratectomy and transepithelial photorefractive keratectomy for myopia. It was a retrospective cohort study consisting of patients who underwent PRK between 2014 to 2017. The time frame for follow-up was a 2-year period. At the baseline, all patients underwent ophthalmic examination, including refraction, visual acuity, slit lamp biomicroscopy, dilated fundoscopy, and corneal topography. Written informed consent was obtained from all the patients, and the follow-up period was done at 1 month, 3 months, 6 months, 12 months, and 24 months. The inclusion criteria for this study was any patient who had undergone PRK surgery in their hospital for a refractive error of -5 diopters spherical equivalent or less, and patients who were aged more than or equal to 18 years. The exclusion criteria for this study was patients with any history of ocular or systemic diseases who were followed up for a period of less than 24 months and any history of previous eye surgery. So coming to the surgical technique that they used for the MPRK, the periorbital skin was cleaned with a 10% povidone iodine solution. Sterile drape was applied and attached to the blepharostat. Central 9 millimeters of the cornea was scraped with a knife and cleaned with a blunt spatula from the center to the periphery with mechanical corneal debridement. Excimer laser ablation was performed with the standard algorithm of the device. Coming to TPRK, the initial steps were the same, but the corneal epithelial removal was done using the OccCam software of the device with an excimer laser in a 7 to 9 millimeter zone. And then the excimer laser ablation was performed with standard algorithm of the device. In both the procedures, a 6.5 millimeters ablation zone was used. Post-ablation, 0.02% of mitomycin C was placed on the stromal bed for a duration of 30 seconds and washed with 40 ml of balanced salt solution. Soft bandage contact lens was applied until epithelialization was achieved. The patients were kept on topical antibiotics and artificial teardrops post the procedure, and topical steroids were started once epithelialization was completed. The statistical analysis for this study, the data was presented with mean, standard deviation, and maximum and minimum values. The Kolmogorov-Smirnov test was applied to assess whether the distribution of patients was normal or skewed data. Appropriate tests, for example, the paired sample t-tests and one-way ANOVA were used in analysis, and a p-value of less than 0.05 was considered to be statistically significant. Coming to the results of this study, a total of 109 eyes of 55 patients were recruited. The mean age of the patients was 26.9 years with a standard deviation of 5.3 years. 45% of the participants were male and 55% of them were female. 49.5% of the eyes were the right eye and 50.5% were the left eye. Amongst the 109 eyes, 40.4% of the patients had undergone a mechanical photorefractive keratectomy, whereas 59.6% had undergone a transepithelial photorefractive keratectomy. Coming to the results of the study, as we can see from this table, in both MPRK and TPRK, there was a significant improvement in the refractive error and uncorrected visual acuity post-operatively, and this result was statistically significant in both groups. This is a graphical representation showing the preoperative uncorrected visual acuity and postoperative uncorrected visual acuity for both the groups. As we can see that the uncorrected visual acuity has improved post-procedure and has maintained a stable value for a period of 24 months following the procedure in both the groups. This is a graphical representation of the refractive error pre-operatively and post-operatively. Again, here there is an improvement of the refractive error post-procedure, which has remained stable over the course of 24 months in both the groups. However, the TPRK group appears to be closer to emetropia as compared to the MPRK group. Coming to the higher order aberrations in both the groups, as we can see in the MPRK group, in the central 4 millimeter zone, the total aberrations increased post-operatively, and this was statistically significant. Whereas in the 6 millimeter zone, the total aberrations, comma aberrations, as well as the spherical aberrations increased significantly post the procedure. In comparison to this, in the TPRK group, in the central 4 millimeter zone, the change in aberration profile was not significant, whereas in the 6 millimeter zone, the total aberration and the spherical aberration were increased significantly. No serious side effects were noted during the course of the study. Late onset corneal haze was noted in 3 eyes who underwent MPRK, which were responding to medical management. In this study, refractive and visual results are at par with what is seen in literature. In the MPRK group, the preoperative refractive error was minus 2.33 diopters with a standard deviation of 0.88, and the postoperative refractive error was minus 0.27 with a standard deviation of 0.32 diopters. In the trans epithelial PRK group, the preoperative refractive error was comparable at minus 2.19 with a standard deviation of 0.73 diopters. And the postoperative refractive error was minus 0.14 with a standard deviation of 0.32 diopters. Both methods were found to be successful at the end of 2-year period. And based on the results noted for the higher order aberrations, it can be concluded that the TPRK group is slightly more advantageous than the MPRK procedure. Coming to the limitations of this study, it is a retrospective design of the study, and there is a limited sample size. The strength is that there was a long follow-up for a duration of 2 years, and apart from the visual and refractive outcomes, it compares the higher order aberrations as well. So, as I mentioned before, coming to the MARI index methods, it was a retrospective study design with well-defined inclusion and exclusion criteria, with a 2-year follow-up and a small sample size. Assignment, informed consent was taken, but the study was limited to 1 geographical location. Assessment, the uncorrected visual acuity and the refractive error pre- and post-operative results were compared, and higher order aberrations were also compared. Results, both the TPRK and MPRK were successful at the end of 2 years in improving the visual and refractive outcomes, and greater higher order aberrations were seen in the MPRK group as compared to the TPRK group. Interpretation, the TPRK group can be considered more advantageous in decreasing the higher order aberrations as compared to the MPRK group. Extrapolation, it is a Turkey-based study, including only people from one particular geographical area, and a prospective study design with a larger sample size, including a diverse population, would give us more knowledge. These are some of the other studies that were reviewed in the literature with this journal. 4 studies here compared, the initial 4 studies compared the refractive and visual results post-operatively, and all of them showed a significant improvement. Naderi et al. Compared MPRK and TPRK in 340 eyes, at 6 months duration. With the TPRK, the mean spherical and cylindrical refractive error was minus 0.09. And with the MPRK, it was the mean spherical error was minus 0.05, and the mean cylindrical refractive error was minus 0.01. And the mean refractive error values in TPRK were statistically significantly lower, both spherically and astigmatically. Lee et al. Studied the change in the higher order aberrations seen after TPRK. Preoperatively, the mean spherical higher order aberration was noted to be 0.29 with a standard deviation of 0.08. This increased significantly post-operatively to 0.51 with a standard deviation of 0.2. The comma higher order aberration remained comparable both pre and post-operatively. Thank you.
So,
Thank you, Dr. Aarti. Yeah, very well presented. Congratulations to you.
Thank you.
And congratulations also to your mentor, Dr. Rama Rajagopal. So, yeah, Dr. Rama Rajagopal, you had any comments to make? Please go ahead.
Yeah, before we move on to the discussion with the panelists, I have a few comments to make about the paper itself. I think it's a very structured and well written paper comparing two groups of surface procedures and their higher order aberrations. But there are a few limitations, like the authors themselves have said. Because it's a retrospective study, there is no randomization that is possible. But there is also one thing that we don't really know the methodology on how they arrived at the sample size. So basically, there is a procedure. They go over the retrospective studies and then understand what actually studied in the paper and place it on the sample size. There's no clarity on the methodology of the sample size that they arrived at. It seems to be a convenient cohort kind of a study. The second point is, I think, usually in refractive surgery outcomes, we describe the outcomes in terms of safety, efficacy, predictability. Although they have given their results in terms of uncorrected vision, best corrected vision, I think they have not categorized them in these specific groups. The third point is, what was the defining criteria for a group of patients to go through trans-PRK, and what was the indication for patients going through MPRK? I'm sure they must have had some criteria for that, although it's a retrospective study, but there's no clarity on whether it was patients who wanted faster recovery and less pain, who opted for trans-PRK, was it a surgeon's preference, or was it a little bit of cost factor that some patients opted for the MPRK group. And fourthly, I think one of the important advantages we all know of trans-PRK is the rapid epithelialization and the less pain. Although it is difficult to quantify pain in a retrospective study unless you have a prospective study that is going on, it would still have been possible for them to look at the rate of epithelial healing between the two groups. While they have looked at other parameters in terms of refractive error and vision, I'm a little clueless as to why they have not looked at the rate of epithelial healing comparison between the two groups. So this is as far as my observation with this journal is concerned. I have a few questions for the discussants, if I may. The first thing is, what is the panelist procedure of choice? Do they do trans-PRK? Do they do alcohol-assisted? Or what is their preferred choice of procedure? And secondly, I also want to know, is epithelium mapping, although it was not done in this patient, is this a requirement in all refractive procedures as a part of screening, or like we do now, do you do it in select cases where you have changes in the anterior map, or when you have a steep cornea with a thin K? There are certain indications where you definitely want to consider epithelial mapping, but should it be considered as a routine in all parts of screening in surface procedures? And if they have any opinion on the higher order aberrations profile that they see after these procedures, I would just like to get the panel's opinion on that also. Thank you.
So yeah, we'll quickly take these questions and then we'll move back to discussing the journal article, the analyzing the journal article per se. So we can go ahead with the Dr. Vardhaman, you first.
So I think very, very nicely presented again, Dr. Aarti. Coming back to the questions posted by Dr. R.R. ma'am. Basically, when it comes to the procedure, now, of course, it depends on which examiner one has access to. I think that is going to be a big, let's say, prerequisite if you want to do trans PRK. Currently, we have access to both the Zeiss MIL90 as well as the EX500. And with EX500, we prefer to perform a trans epithelial PRK as long as we are able to get a extremely reproducible and very good quality epithelial map. So in trans PRK, it is actually a kind of mandatory requirement that you should have a very good epithelial mapping, because if you don't have it, then you are actually presuming everybody to have a 50 micron epithelium, which is actually not the case truly. So number one is that epithelial mapping is very, very crucial. And if your epithelial maps are not very regular, not very reproducible, for sure, either if the patient has been contact lens wearer, etc., then you should treat that factor first, make the epithelium more regular before you have undergone the procedure. And in spite of that, if it is not possible, definitely it is better to actually remove epithelium mechanically, either with the help of alcohol, or you can use a beaver for that. That should work very well. But vast majority of the patients, 80-85% patients, when the epithelium is actually reproducibly quantifiable with epithelial mapping, I would prefer a transepithelial PRK. Currently, only 2 examer lasers can do that in one go. One is the, of course, the Alcon EX500, and the second one is the Schwind. Both of them do equally good job at that. Coming to the, I think, other question was the importance of epithelial mapping, whether we use it. I use it, especially if I use it selectively in all of them. Actually, I use it in all of them. It is part of the refractive workup in each and every patient, because the epithelial mapping is very, very crucial in, I think, variety of circumstances. Of course, one of them being in these scenarios when you're actually planning a transepithelial PRK, where it is a must. But if you're looking at a cornea which looks suspicious, it is very crucial that you actually try to see the steep area on your topography and match it with the thinnest of the epithelial maps that are there. I think that is going to be discussed also in the next journal that we are going to present, like discuss today. Of course, it comes handy in many retreatments if you want to do enhancement, if you want to look at patients who are having contact lens warpage, differentiate that between warpage versus a possible early K-conus. Also plan advanced treatments of keratoconus such as Cretan protocol or TREC. For that, your epithelial mapping is going to be crucial. So we do it in each and every case as long as one has access to. If one does not have access to epithelial mapping, then if your topography looks suspicious, I think you should send it out to a center where their epithelial mapping is done. Try to actually correlate both of them and take the right call, is what I would like to say. I think definitely I would like to also listen to both Dr. SKR sir and Dr. Rohit about their.
Thank you, Dr. Vartman. Dr. Rohit Shetty, sir, any comments?
Again, an excellent pick of journal and nicely presented. One important thing is when you talk about aberrations or and all these higher order optics, it is one big flaw with any studies, including this one, is not having an epithelial map, because 3 to 4 microns difference, or average around 7 microns difference from the center to the periphery, would induce coma, induce spherical aberrations, or induce any kind of aberrations which probably would go unnoticed. As Vartman said, not having any pre-op data on the epithelium and then making assessment of the aberrations is a big flaw. And I think this is something which should take home from this study, is that without that, these articles have little relevance, because if there is an epithelial hypertrophy or centrally cornea becomes thicker by around 8 microns, 10 microns, and periphery is thinner, so it would induce a lot of spherical aberration, which would amount to a huge amount of shift in the data itself. And the Schwind platform takes epithelial maps from different machines, including MS-39. So it takes the central and the peripheral. So a lot of new things have been incorporated into the topo-guided treatments. However, if like Dr. Ramya said, that if you have not taken into consideration the reason for doing a topo-guided PRK, or just a PRK, it's again a big rate limiting factor here, because if you're taken a contact lens patient and you've done a PRK versus a non-contact lens patient, your results are going to be completely different because the contact lens patient would have a different epithelial profile and would need a different type of epithelial remodeling. And that's the biggest flaw. The second is the status of ocular surface and dry eye, because that contributes heavily to wound healing. And if you have taken a contact lens person, the wound healing is different. How it heals after 2 months or 3 months is different. So, and post-operative medications, if you're given your patient, say, cyclosporin, your epithelial remodeling is different compared to a non-cyclosporin. So, I feel that this is a good study, but to me there are a lot of flaws. So, if somebody wants to take it forward, I think if you incorporate everything and build a good cohort, and these are studies where it has a very good scope for an AI, because you're looking at around 30, 40 parameters of both from the patient related, the imaging related, the topography and other related. So I would suggest that if you collect more data and build a good AI on it, you might get factors which makes your AI on epithelial healing, but I mean, this amounts a larger data cohort, something similar to what has been done, but with more clarity. So these are my inputs on this in particular case.
Thank you.
Thank you, Dr. Rohit. So you've given us a very good insight into how to actually critically analyze an article. And that's exactly what we want our PGs to develop, not to just take an article at face value, but to look at all these different parameters and, critically analyze every article before consuming it. Dr. Srinivas Rao, sir, any by Dr. Rama?
Not particularly. Basically, I think this highlights again the point about clinical and statistical relevance. Some of these small differences will often turn out to be statistically significant. But then the question is, does it turn out to be clinically significant as well? And are you convinced enough about the transepithelial PRK that you'll go around and shift your laser from your existing one to a new one? Will you invest in a new one? Because the data from this study shows you conclusively that it's a much better way of doing it. And as they've analyzed in their own discussion, there are other papers which are showing contrarian results as well. So again, like Rohit was trying to say, it's very difficult to get a very homogeneous population. I think Rama made that point as well. So small differences like these, unless you have an absolutely standard patient population, is very difficult to do. One way to do this would be to do it in contralateral eyes of the patient. You do one procedure in the one eye and do the other procedure in the other eye. You don't exactly take care of all the variations, because Rohit mentioned there were more than 30 of them. I'm sure he knows that. But at least some of the biological variables get evened out to some extent. Maybe it's hard to explain to the patient or to get him to agree to doing one procedure in one and then the other. In the early days of a new procedure, it's possible, but now these procedures have been around for so long that you have to choose one or the other. But from a study perspective, one way to iron out some of the differences.
No, I don't think we heard the last line that you said, Dr. Rao. You just sum it up, please. There was a problem with your issue.
Now, I was just saying that in these kind of studies, when you're looking at a lot of variations in the healing and so on, which could influence your outcomes, one way might be to use two different eyes of the patient and do the procedure, one procedure on the one eye and the other procedure on the other. So to some extent, some of the variables get evened out between the two procedures. So the healing response is likely to be the same in each eye of the patient to some extent. So that might be one other way to do a future study on this particular aspect.
Thank you. Yeah, very well highlighted. Dr. Vardman, anything else that you'd like to comment on the article as such?
Yeah, so I think as Dr. SKR sir just said, the best way to do such very close competitive comparative studies is to do randomized contralateral studies, because that is the closest that one can come to. And if that is possible, to have similar cohort of both spherical equivalent being similar in both eyes and and the other things should be also matching, including equally good topographies in both eyes and everything else. So I think that is the closest that one can come. That can be a good way of doing future study. In fact, there is a very good meta-analysis which has been done on comparison between the mechanical debridement versus the transepithelial PRK. And generally, let's say that the study outcomes have been almost similar. I think there are only 2 studies which have actually looked at contralateral randomized studies in that meta-analysis as well. Some of the secondary outcomes in trans-PRK are better actually rather than the primary. Primary being your predictability, safety, and efficacy. In fact, all of them generally have been seen to be similar. But the secondary parameters, including epithelial healing time and your pain score, that can be only evaluated in a prospective study, has been seen to be better in trans-PRK. Generally speaking, if you don't have access to the lasers which can do trans-PRK, then the best thing is to actually perform. Then you will be less dependent on epithelial mapping, frankly speaking, because when you have been doing trans-PRK, epithelial mapping is a must. But if you have other lasers which work equally well, then epithelial mapping may not be a mandatory tool when you are actually performing a PRK procedure. Second thing that you should look at is which journal you are taking the article from. Now, like this journal that we have looked at, you have to look at the impact factor of the journal. The impact factor will actually denote what is the possible, let's say, cross citations that this journal article averagely is going to take out, right? So basically, if you are taking a journal which is from the top refractive journals like JRS or JCRS versus the one that you have taken, I think it is a Turkish journal is what I understand. Definitely the one which are from those very reputed high impact journals will be better in terms of their methodology. They will be definitely, because to qualify to publish in those journals, you have to really do a study which is very, very methodical. So in this study, actually, there were many flaws, as we said, basically no randomization, of course, and they have not really discussed also how they have calculated the higher order aberrations. If you look at, in fact, there is no, in fact, the tool or equipment is also not mentioned. So I think these are very big drawbacks, actually, if you want to really write an article. So you have to have a very standardized way in which you perform the study and then you write the study, because both of them become equally important. So I think one take home I will say is that when you want to study any article, try to choose from the journals which are from the high impact journals. In fact, now IGO has also become one of the top journals in that way. I think in the last 5 years or so, we have seen that it is actually impact factor has also gone up. But your methodology becomes very, very crucial. And the way you write it later on also becomes crucial. Like for postgraduate or residents like yourself, if you want to write something, taking inspiration, then you read more articles which are published in journals. Also choose authors who have a reputation of very high impact factor articles with a lot of cross citations, like George Alio, like you have mentioned his study just now. And if you see, he had the longest follow-up for a PRK that was there in the Volt series. So these are the kind of things that you should choose. So always read the article, go to the cross citations, read all those articles also from the high impact factor journals. I think that should be what I'll say. Yeah.
Thank you, Dr. Vardhan. Excellent take-home message. Dr. Chintan, would you like to add something to this? You're on mute.
Yeah. So I think most of the points have been highlighted by Dr. Rao, Dr. Shetty, and Dr. Kinkaria. And I agree with Dr. Rao sir that we really have to look at it with a pinch of salt as to, in terms of how much of a benefit does it offer the transepithelial PRK. And the studies which Dr. Kinkaria mentioned, I think I agree with each of those points that once, as residents, when they have to design studies and look at studies, because they'll be doing their thesis, their prospective studies, or even the retrospective data for that matter, that is useful sometimes as to how to go about it stepwise and how to manage it. So I think everything's been that was there to be covered has been covered. Thank you.
So if anyone else has any comments on this article, otherwise we'll move on to the second article. Okay. Thank you, Dr. Aarti, and thank you, Dr. Rama Rajagopal, for that excellent presentation. And I think we had a very good discussion on this. We'll move on to the next presenter. So our next presenter is Dr. Lekha Chandel, who is a cornea, cataract, and refractive surgery trainee at the Advanced Eye Center, PGI Chandigarh. Her mentor is Professor Chintan Malhotra from the Cornea, Lens, and Refractive Services at the Advanced Eye Center, PGI Chandigarh. And her article of choice is Corneal Ectasia Detection by epithelial pattern standard deviation from OCT. So over to you, Dr. Lekha Chandel. Looking forward to your presentation.
Good evening, everyone. I'll be sharing my screen now. So, good evening, everyone. I'll be presenting in this journal club. My mentor is Professor Chintan Malhotra. The article I'm presenting was published in JCRS in October 2023. The title is Corneal Ectasia Detection by Epithelial Pattern Standard Deviation from OCT. The corneal epithelium plays an important role in maintaining the high optical quality, and the compensatory changes in the epithelial thickness. There are compensatory changes in the epithelial thickness in response to surface irregularity because the corneal epithelium shows remarkable plasticity. The epithelial thickness mapping has been done earlier with various instruments. The most common is the very high frequency ultrasound and spectral domain OCT. And it has various applications, but one of the most important ones is detection of subclinical ectasia, because it gives us the opportunity for timely intervention. So the aim of the study was to test the ability of the corneal epithelial pattern standard deviation to distinguish between normal and cases with corneal ectasia. The study was a cross-sectional retrospective study, and it was conducted at Brazil. The inclusion criteria had 3 groups. First was the normal group, which had normal eyes and unremarkable biomicroscopic examination, the corrected distance visual acuity of at least 20/20, the normal subjective tomographic pattern, and normal objective variables from the BAD map. Second group contained keratoconus patients. The diagnosis was based on the criteria from the collaborative longitudinal evaluation of keratoconus study, and it also included topometric and topographic findings from elevation-based corneal curvature maps. The third was very asymmetric group. It consisted of cases of confirmed ectasia in one eye and the fellow eye with normal tomography. The keratoconus percentage index score of less than 60 and paracentral superior inferior asymmetry of less than 1.45. All the patients with reporting any ocular surgery or presenting with extensive corneal scars were excluded from the study. The patient underwent comprehensive ocular examination performed by a fellowship-trained refractive surgeon. The patients also underwent Scheimpflug corneal tomography, Fourier domain OCT, and corneal biomechanics were assessed by Oculus Corvis ST. The patients were divided into 4 groups. The group 1 consisted of the patients with normal tomography. Only one eye was randomly selected from the 105 patients. Group 2 consisted of keratoconus patients. The number was 86. One eye of the bilateral keratoconus patient was selected. Group 3, which was very asymmetric ectasia, were the ectatic eye with typical keratoconus pattern with no surgical intervention for keratoconus. And group 4 were the fellow eye of group 3, which was fellow eye with normal topography and tomography from group 3. The patients underwent Fourier domain OCT with wide-angle corneal adapter module. The pachymetry CPWR scan configuration was, as mentioned, each eye was scanned 2 to 3 times during a single visit. The corneal thickness was automatically measured as the distance between air tear and cornea aqueous interfaces, and corneal epithelial thickness measured as the distance between air tear and epithelial Bowman interfaces. The epithelium pattern standard deviation maps were calculated comparing the epithelial pattern map to the average pattern map from normal subjects. The epithelial pattern standard deviation variable was calculated using central 5 mm diameter using a specific formula, which was used in a previous study by Yan Li, which was published in 2016 in JCRS. These formulas look fairly complicated, but the idea was to calculate the epithelial pattern map of normal reference population and then individual epithelial pattern maps, and then finding the difference between the two. The Kolmogorov-Simrov test was used to assess whether the parameters was normally distributed. Non-parametric Kruskal-Wallis test was used to assess the difference among the groups, followed by the post-hoc Dunn test for pairwise comparison. ROC curves were calculated for each parameter tested to determine the variable overall predictive accuracy. The area under the ROC curve was also calculated, and a cutoff value of each variable was selected with the highest average of sensitivity and specificity. The pairwise comparisons of the area under the ROC curve were performed. P-value of less than 0.05 was considered statistically significant. Coming to the results, in demography, they had 105 normal eyes, 86 keratoconic eyes, 11 ectatic eyes whose fellow eyes had normal tomography, and 61 fellow eyes with very asymmetric ectasia. There was no statistical difference for patient age or sex between the groups. The mean age of the patients was 31 years. In this, we can see the epithelial pattern standard deviation between all the 4 groups. And what we can see is that the normal group presented significantly lower epithelial pattern standard deviation than both the ectasia group, which is group 2 and 3, and the very asymmetric ectasia normal topography group. But I would like to highlight here that the mean is comparable between the normal group and the very asymmetric ectasia with normal topography group. So, but the results they had found were statistically significant in epithelial pattern standard deviation. This can be attributed to the one outlier that they had in the very asymmetric ectasia normal topography group, which had a maximum value of 0.15. So the differences among the study group for all the variables were statistically significant. The other variables which were tested were epithelial pattern standard deviation, inferior superior asymmetry value, Kmax front, KISA index, Vardy map, Pentacam random forest index, CBI and TBI. So the ROC curves were drawn between the various variables. The area under the ROC curve for pattern standard deviation of epithelium for detecting clinical ectasia was 0.979 with 93.7% sensitivity and 94.1% specificity. We can see here that the Pentacam random forest index, Vardy map and TBI performed much better than the epithelial pattern standard deviation map in detecting clinical ectasia. In this ROC curve compares normal cases from the subclinical cases, which is our area of interest because that is where the application is most important. So the pattern standard deviation of the epithelium had a statistically lower area under the ROC curve for detecting normal topography eyes, and it performed lower compared to the other variables where Pentacam random forest index and TBI performed much better. The conclusion is the corneal pattern standard deviation of the epithelium derived from the OCT is capable of distinguishing the epithelium thickness profile in normal and keratoconic eyes, but it did not demonstrate high accuracy to identify milder forms of the disease and could not be used isolated for the frustrate form of keratoconus. The corneal pattern standard deviation can be used as an adjunct to the other parameters. This study had various limitations. The OCT technology was limited to 6 mm diameter of the thickness map. It did not investigate the differences in the pattern standard deviation values according to stages of the keratoconus. Normal topography eyes might be truly unilateral ectasia and never develop any clinical or tomography sign of the disease. The pattern standard deviation detects many types of abnormalities and it is not specific for keratoconus like epithelial basement membrane dystrophy, corneal warpage. And mean age of patients was not representative of the target population because the patient tested here are in the 4th decade and the presentation for subclinical ectasia has been found to be in 3rd decade. The contact lens type, the contact lens duration of use, and the number of contact lens wearers were not specified in this study, and the washout period was 3 weeks for every type of contact lens. Basically, they did not mention the type of contact lens. And remodeling occurs in response to anterior corneal curvature change. So posterior corneal elevation may be a better indicator for early ectasia. Contact lens data could have added value to the study, and maybe AI-based algorithms can be used to incorporate all the parameters to increase the sensitivity of screening. Thank you.
Thank you, Dr. Lekha, for that very excellent appraisal of your journal article. You very well highlighted all the strengths and weaknesses of this article. And I also congratulate Dr. Chintan Malhotra for being the mentor. Very nicely, all the points were very nicely brought out. So, Dr. Chintan, anything that you'd like to add to this presentation? Anything else?
Yes, I have a couple of comments to make. For the residents listening out there, we all know that epithelial mapping is, it's the sort of the new toy we have or the new kid on the block. It definitely has its uses both in diagnosis as well as therapeutics, there's no doubt. But as regards the journal, I think if we start from, although it's published in a good journal and authors who have experience, but the limitations, according to me, would be that one, the title itself is not truly reflective of, what should have been the focus of the study. It's well known that in established ectasia, the epithelial mapping will show a difference. It will be thinner than the others. Where the true value lies, as Lekha has also pointed out, is in the form-fruste forms of the disease. So although it did analyze those results, but in the title, when one reads the title, one does not get the impression that one is, going to be looking at subclinical cases or form-fruste cases. Second, the terminology that they've used throughout as we all know that there's no clear-cut definitions for form-fruste keratoconus and subclinical keratoconus, and often they are used interchangeably. But what makes more sense to me is that, or most articles, what they say is that form-fruste is when it is the topographically normal eye of the contralateral eye having keratoconus, and subclinical would kind of reflect a topographic abnormality, but no clinical abnormality in terms of vision or clinical signs. Here, the authors have used, in the abstract, they use the term form-fruste. When they're describing the title, the tables, they've used the term subclinical, which itself can lead to a difference in interpretation. Thirdly, the abstract and the conclusion of the abstract and the conclusion of the paper, they speak completely different languages. So if we see the abstract, the last line of the abstract says that the pattern standard deviation was useful even for detecting changes in the form-fruste form of the disease. Whereas in the paper itself, they very clearly say that it performed much lower than the other parameters, and it can just be used as an adjunct. So if one were to go by the abstract, and that's for the residents again, you have to read the study in detail. It cannot be just going through the abstract without really, teasing out the finer points of the study. Many other points, but the last one I think I'd like to make before I hand it over to the other the discussants is that what Lekha again pointed out, the difference which they showed, a value of 0.008 difference between the normal eyes and the contralateral eyes, which were apparently normal. So 0.0008 p-value is highly, highly significant. But that probably is attributable just to that one outlier, because if you see that map, the cluster map that they showed, everything was very tightly packed between the two groups. So it was just probably that one outlier which led to that difference. And I think that's where we have to learn to, tease out the differences. So the abstract and the articles conveying different implications, I think, is the biggest limitation of this study.
Excellently highlighted, Dr. Chintan. I mean, you've highlighted how we should not just read the article, but also read in between the lines whenever we are analyzing an article. So I'll now invite the discussants for their comments. Dr. Rohit Shetty, your comments on this article.
I think Chintan has very beautifully articulated the challenges of doing. I mean, it's not, I'm not talking about in this particular paper. Any paper which works on epithelium is a very difficult paper to have a research question and find a conclusion which fits into your research question. The reason is epithelium is such a dynamic structures. If you do an epithelial, one is the repeatability of any machine. Every machine has different repeatabilities, and people are looking at 3 microns, 6 micron, 8 microns difference. If you do I've used all epithelial mappers. The average repeatability is around 6 to 7 microns. And it changes during the morning. You make the patient sit in an AC and come. There are so many epithelial cells keep changing. If you're especially in keratoconus, it's very difficult to make any assessment of an epithelium because your eye rubbers. If you sleep on one side, if you use a patient who's sleeping on the right side versus the left side, or if he's putting a pressure on the eyes, your epithelial map is completely different. Your an eye rubber is completely different. Contact lens is completely different. Ocular surface is different. So even if you have to do a very good epithelial map, the epithelial map related indices, you need to have a very, very high resolution OCTs, and all the even this OCT you're talking is around 4 to 6 microns resolution, which is not a great tool. See, most of the original work which people talk about epithelium as an important factor in refractive surgery was based on Dan Reinstein's paper where he used Artemis. And Artemis has a resolution of close to close to 1 microns. And it used to give you all the patterns. And we have extrapolated that to our OCTs, which are different resolution capacities. And as rightly said by Dr. Lekha, she said 6 millimeters is the area of what this measures. And but what happens is it's not lost hope. There are new technologies today like MS-39, which has come, which looks at epithelial map and the stromal elevation. And one of the things what I think the last point with Dr. Lekha mentioned was looking at the anterior and posterior elevation, and combining the epithelial map with the elevation, a stromal elevation is the way to go. But however, if you want to take this study up, I think Dr. Chintan has the I think you have the TOMI system, and TOMI system gives a little wider view. And I don't know at this point of time you have an access to MS-39. So I mean the whole idea of these studies is for the residents and fellows is you have to pick up what has not been done. And see, when you write those limitations in your journal club, I tell my fellows that the limitations are for you to work on. And every limitation, what you mentioned, that 9 or 10, which is there in one slide, is a paper by itself. And if you can start looking at those limitations and start working, you probably will contribute much stronger to the current literature. Because, and both this paper and the previous one, I think the take-home point here is not about what was wrong. I mean, of course, even if I look at my paper written 5 years back, I'll find 25 limitations which I should have addressed then. But if you go back and look at those limitations and start writing it up and asking some relevant question, you might come out answer to a lot of them. For example, just the repeatability of different machines taken in different conditions itself is a very good paper. Not many papers do have. And eye rubbing versus non-eye rubbers in keratoconus, how does an epithelium behave? It's a very good question. And we have published some work about the biomarkers and the epithelium. The eyes with more MMP9s and IL-6 have a different epithelial maps compared to non-inflamed eyes. So my advice to you is to pick up those beautifully written limitations and convert into a good research topic and publish it. Otherwise, excellent work.
Thank you, Dr. Rohit Shetty. I mean, you've given some excellent ideas to the PGs in that very short and, the comments that you made. Dr. Srinivas Rao, I would like your comments on the article.
I think just taking off on where Vardhaman finished the last discussion, this is a good journal, the JCRS. Ambrosio has done some of the pioneering work in this area. So you have an expert author and his team. And he's got a fairly standard methodology. But so far, we've been looking at epithelial map patterns and trying to look at donuts and so on and say that these are suspicious eyes when you have, topography is not 100%. So now you've gone differently. You're trying to look at pattern standard deviations over the central 5 millimeters, which, because these devices now give you so much of data, there's a temptation to just look at the data. You can do anything you want with these numbers and look at it. But keratoconus is an inferior disease. You're looking at the central 5 millimeters. So you're going to look at the epithelium over a large part of the normal cornea as well, and you're averaging it across this. So technically, it doesn't make sense. You're just trying to look at new parameters. So just wanted to say that when you're looking at journal articles, it takes a long time to read an article, at least an hour and a half for me to go through it in detail. So I think the first thing you must do is, like Vardhaman said, good journal, good author, all that is good. Go through the abstract very briefly. First, look at the conclusion and see whether it makes sense for you at all or not. Only if it makes sense, then you invest time in reading the actual paper, because the paper tells you whether that conclusion was arrived at in a proper manner or not. But if the conclusion per se is not particularly relevant, and in this conclusion, they just concluded that, yeah, it is an interesting way of looking at it, but compared to the current standard metrics, it is no better. In fact, it fares poorer. So personally, I wouldn't even go through the paper anymore. I would just know that there's an article that's trying to look at epithelium across the central cornea and it's promising. I would wait for better quality data to come before I invest an hour of my time reading this paper. Because with these kind of new parameters that are coming out, many of them are just, parameters, that's all. Applying them clinically and making sense of them and using them on a daily basis, we're a long way away. So before you invest time reading these articles, I think scan the journal abstract very quickly, find out whether it's relevant. If it is relevant, know about it. But do you have the Oculus HR thing that they have to measure the 5 millimeters of the epithelium? If you don't, then it's just interesting information. You can't really use it. So look at the journal from these perspectives as well. So this is nothing new. We know about epithelial mapping in abnormal corneas. It's already been there for a while. So this is not new information. They're looking at it in a slightly different way, and they've shown you that it's not at this point particularly, a solid way of looking at it. So this is just the take home. Before you read the journal completely, article completely, make sure that the conclusion is worth the time that you're putting it in.
Thank you, Dr. Srinivas. Dr. Vardhaman, any comments on the article?
I think, all the limitations and the strengths have been discussed very well, articulated very well by all of them, by Dr. Chintan, Dr. Rohit, and Dr. SKR sir also. And I agree with all of them, especially what Dr. SKR sir said, because when you read an article, there are two ways that are important for you. Number one is that whether you are a researcher or whether you are a clinician, what point of view you are looking at the article. If you're looking at the article as a researcher, definitely I think what Dr. Rohit said is very crucial, that you have to look at the limitations to see if you have that technology available with you, try to add to the science, and then see where it takes you. Like, for example, I think for this group of Dr. Ambrosio, this is the same group which came with the BAT-D display and everything else. So they work a lot with the data. They work a lot with the analysis of this data. And now with the new advent of AI, they would try and incorporate a lot of these things which they come up with ultimately with the newer technology that we have. Like if there is a MS39 which has epithelial mapping as well as topography, maybe you can integrate and you can come up with a new indices. So that can happen in the future. But as a clinician, when you look at this paper, probably there is nothing that you can really take away or extrapolate, because as of today, when you look at the epithelium, it is more of a qualitative thing that you have to correlate with your tomography, with your topography and the epithelial mapping, than only this very specific Panther standard deviation, which is happening only in the first 6 millimeters, and which is a big drawback of this study, as we have seen. But definitely, let's say a good study with a good journal by a good group, and you can learn as a resident how to write a paper, how to actually come up with some good methodology, how they have selected the patient pool and everything else, and use this learning in any of your newer study that you would like to do. So there are some definite takeaways from the way you look at this journal. But if you, in the future, when you become a clinician, you have to also look at different journals and learn from it to extrapolate and help your patients. So that is when you have to differentiate what is only as a research tool versus what you can extrapolate as a clinical entity.
Thank you, Dr. Vardhaman. Dr. Rama Rajagopal, I would like you to add some comments to this.
I think everything has been beautifully highlighted by the presenter and Dr. Chintan and the panelists. I think so much as the variability with respect to epithelial mapping in terms of parameters, taking on from where Dr. Rohit said, I think there is a study that has actually looked at how the parameters change in keratoconic patients between 3 different machines at the same point of time, and they have found that the repeatability and agreement between the machines is not always the same between different set of machines. And at the best, if you're doing these studies, you may want to consider doing it on the same machine over a period of time, because there are definite differences. And considering the fact there are so many variables that have to be looked at in these epithelial mapping, one has to carefully look at every single parameter to actually get the best out of your interpretation of these epithelial maps. Thanks.
Thank you so much. So if there are any more parting comments, I would be happy to take them. Otherwise, I think we've reached the conclusion of this webinar. I think it's been a very, very interesting webinar, very excellent presentations by Dr. Aarti Rajkumar and Dr. Lekha Chandel. You very well brought out all the weaknesses and all the strengths of the studies that you presented, and you appraised them very well. I also congratulate the mentors, Dr. Rama Rajagopal and Dr. Chintan Malhotra. And last but not least, the panel of discussants, Dr. Rohit Shetty, Dr. Srinivas Rao, and Dr. Vardhaman Katkaria. Your comments were very valuable indeed. And I think this journal club will go a long way in stimulating the minds of our postgraduates as and when they read and evaluate a journal article. So with that, I bid you a very good night. Thank you all once again for your presence here this evening, and hope to see you again in future webinars. I also thank our audience who had logged in, and I hope it was a fruitful webinar for them as well. Thank you so much. Thank you all.
Good night, everyone.
Thank you.
Bye-bye.
Good night.
Thanks.
Thank you. Bye. Good night.
Good night. Bye.